Our next presenter is Dr. Oliver Tobin. Dr. Tobin could not be with us today, but he recorded his presentation. He had a family emergency. He recorded his presentation a couple days ago and got it to us. So if we could go ahead and queue up Dr. Tobin's presentation. Here we go, folks. All right. Thank you.
Hi, everyone. My name is Oliver Tobin. I'm the neurology representative of the Mayo Clinic Histocytosis Working Group here in Rochester, Minnesota. I'm sorry to be coming to you by video today. I was really looking forward to this meeting, both the scientific session and the patient and family gathering, but unfortunately, I was called away for family reasons. But I'm excited to share with you some insights about neurologic involvement in histocytic disorders today. These are my disclosures. Unfortunately, we don't have any funding for our histocytic work here at Mayo Clinic, but do have quite an active group, as I'm sure you already know. So, as you know, there are many different types of histocytic disorders, but the three most common disorders that we see, at least in adult neurology practice, are Erdheim-Chester disease, Langerhans cell histocytosis, and Rosay-Dorfman disease. And neurologic involvement is quite common. In particular, Erdheim-Chester disease, where up to 50% of patients might have neurologic involvement. And this really depends on how you define neurologic involvement, because if you include the skull as being part of neurologic involvement, the rates of disease are higher. It's important also because, particularly in Erdheim-Chester disease, patients who have neurologic involvement tend to have a higher rate of death. But this is contrasted by these patients having a very high response rate to medications. So, I think the era of targeted therapies for histocytic disorders is really exciting, and most of the natural history data that we have predates the more recent advances in therapeutics. And so I think there's a lot of room for excitement and for positivity in management of these disorders. So what does it mean to have involvement of the nervous system? Well, as I said, it depends on your definition, but this is our kind of classic presentation of somebody with a histocytic disorder. So this is an MRI of somebody's brain looking at their cerebellum, which is the balance part of the brain. And this here is the cerebellum, and this should be black, this color up here all the way through. And you can see where the arrows are that there's quite an amount of white here, which is abnormal. And when the patient is given contrast dye during the MRI and that's injected into the vein, that contrast dye leaks across the blood-brain barrier, and you see these large globules of contrast within the pons and cerebellum. And these typically don't respond very well to treatment from the point of view of steroids. So the typical story that we may get is that a patient is treated with steroids and there's a little reduction in the amount of enhancement, but not very much. And that's very typical of histocytic disorders. And patients who have involvement in this area typically present with eye movement problems, so double vision, unsteadiness or ataxia, and sometimes swallowing difficulties or speech slurring. So often patients report that somebody thinks that they're drunk or that they look like they're drunk because of these symptoms. And that's because alcohol intoxication preferentially affects the cerebellum initially, which is why you get unsteadiness with alcohol as well. Now, the other very common area of involvement with brain disease is in the pituitary. And so the pituitary is this small gland right in the center of the brain, behind the eyes. And it's very important for controlling metabolism and salt and water concentrations within the body. So it's a small gland, but really quite important. And this MRI here, you can see there's enhancement to this area of white here, corresponds to the pituitary. So there's abnormal enhancement and the pituitary is large. And these structures here, this is the internal carotid artery, and also in this area is the optic nerves. So the optic nerves come very close to the pituitary here. And if you have enlargement of the pituitary, you can have impairment of hormonal function, so thyroid function, and as I said, salt and water regulation, but also it can give mass effect on the optic nerves, so giving vision problems, either reduction in vision or eye movement problems, because some of the nerves that supply eye movement come through that area as well. An important thing to note about pituitary function is that the MRI is actually not very sensitive for picking up changes in the pituitary. And so about 50% of people who have pituitary problems in the context of histocytic disorders actually have a normal MRI. And so that's why it's really important for people to see an endocrinologist as part of their evaluation, or certainly to have a hormonal screen to make sure that there's not significant hormonal problems. The other area, which it's kind of debatable as to whether it's in the nervous system or not, but the skull. And so you say, well, the skull can be involved, particularly in Langerhans cell histiocytosis. And so this is a patient who presents with a lump on his head, and he can put his finger in through the skull. So this is a CT scan, and this very white area here is his bone. And you can see that there's a piece of that missing at the back, and there's a mass here, corresponding MRI. So there's a soft tissue mass there. And this is a classic presentation of Langerhans cell histiocytosis involving the skull. And interestingly, people who present with just a single lesion involving the skull, that can often regress on its own, without treatment. But certainly you can biopsy that area, and I'm not going to talk very much about treatment in this talk, but in patients who, for whom it doesn't spontaneously regress, you can use treatments in the same way that you can use treatments for any other organ involvement with histocytic disorders. So you can have disease within the brain, you can also have disease within the spine, and then you can have disease outside the brain and spine compressing in. And so this is a patient who has a compressive lesion. So this black area here is the spinal cord, and the belly is up here, and the back here is this is the fat in the person's back. And she has a mass lesion behind the cord, and it's pushing the cord forward and squashing it here. And so this is involvement of the dura, and the dura is one of the coverings of the brain and spinal cord, and the spinal fluid is contained within the dura. And so these are often mistaken for meningiomas, and often operated on, with the intention of removing a meningioma, and so found incidentally. This type of problem would cause, if you have compression of the spinal cord, this would cause weakness of the legs, unsteadiness of the legs, lack of feeling in the legs, and then bladder, bowel, and sexual dysfunction as well. So usually constipation, urinary retention, and maybe erectile dysfunction. This is can occur in all of the histocytic disorders, Erdheim-Chester disease, Langerhans cell histiocytosis, and Rosay-Dorfman disease, but it's most common in Rosay-Dorfman disease, where you have these lesions that are actually outside of the nervous system, but compressing in, and often mistaken for meningiomas. Now, if we go further down into the nervous system, then here we're looking at the lower back. And on the right here is a normal lumbar spine MRI. And so all this white here is fluid, and the normal nerves are actually, they take up actually very little space within the lumbar spinal canal, and they look like a horse's tail, and that's what CAUDA equina means, the tail of a horse. And so here is the abnormal one, and you can see that the nerve roots are thickened. They're almost like beads of contrast enhancement along the nerve roots. And if you flip the person around and slice them like a salami, you can see that the individual nerve roots are clumped together and quite enlarged. And again, this would cause problems in the legs. It wouldn't cause problems in the hands because it's too low to cause problems in the hands, but it would cause weakness, possibly pain in the legs, and again, bladder problems, erectile dysfunction, urinary retention, and numbness in the legs as well. Another place that we can see involved is the eyes. And so here on the right, you have a normal MRI of the eyes. This is the right eye and the left eye. And these here are the optic nerves, so the nerves that basically bring vision from your eye back to your brain. And you can see here within these three panels that there's a huge enlargement of the tissues around the optic nerve. And this is all a histiocytic disorder in infiltration, which infiltrates through the muscles and compresses the optic nerve. And this is a PET scan. And so PET tends to light up with histiocytic disorders. And you can see that this is very bright on PET, showing that it's active disease. And so this can obviously lead to vision loss, blindness, but also double vision and pain. And in this type of case here, you can maybe see that the patient's eyes are actually being pushed forward by this mass that's behind the eyes. And so the person's eyes can look like they're bulging outwards. And that's called proptosis. That's most commonly seen in people who have thyroid eye disease. So an infiltrative disease related to thyroid dysfunction. But in this case, obviously, it's due to the histiocytic disorder. So one of the things that you may hear about is active disease and inactive disease. And so, what does that mean? And so we spoke earlier on about contrast enhancement on MRI. And so patients who have active disease and when they have contrast dye injected during the MRI, the dye will leak across the blood-brain barrier. And you see that as these areas of white here and here. And so this person presented with double vision and then was given steroids. And as I mentioned, the steroids really didn't have that much effect. So there's maybe a little bit of change, but there's still persistent enhancement here. And what that means is that there's still essentially cancer cells within there. The histiocytic cells are still there. And this patient, she underwent actually several biopsies and ultimately was treated with a targeted therapy. And you can see that this enhancement has gone away completely. And so if you look at the bright spots here compared to here, it's completely gone. And what she's left with is a little tiny hole here from the biopsy. And so she has some residual double vision from the biopsy. And so on the left, you say that she has active disease. So there's active cancer there essentially, which is causing her symptoms. But on the right, that cancer has gone away, the histiocytic disorder has gone away, and she may have residual symptoms, but that's from the scar. And so when we say inactive disease, there may be a scar that's left there after treatment or after it spontaneously resolves. The other thing to note is that although we use MRI is a really important tool for evaluating neurologic disease in histiocytic disorders, it's not perfect. And so this person presented with some unsteadiness, and a very astute radiologist noticed that there was tiny areas of enhancement. And I'm not sure if that projects well on your screen today, but these are little tiny dots. And if they weren't looking very carefully, or if the person didn't get enough contrast during the MRI, you really wouldn't have seen that. And so although we look for enhancing disease as the main measure of disease activity within the brain and spinal cord, we still at the back of our mind know that that may not be the full story. And I think we do need to look for other markers for active disease because there is a threshold below which MRI probably won't detect the disease. So I'm going to switch gears here and talk about symptom management in histiocytic disorders. And all the histiocytic disorders are rare. You may think that there's not much data from the point of view of symptom management, but the good thing about neurologic disease is that the symptoms that occur in histiocytic disorders are very similar to the symptoms that occur in other far more common diseases such as stroke or multiple sclerosis. And so we have a good bit of data as to how to manage those. And I'll go through that with you today. So the first thing I want to talk to you about is fatigue, and this is extremely common. And so, on some days our general neurology in basket ranges between 50% and 95% of patients, their main symptom is fatigue, and that's for any neurology presentation. And so there are many causes for fatigue, and the main message is that fatigue can be caused by primary brain disease or by other things. And so, of course, in the setting of brain disease related to histiocytic disorders, it could be related to that. And there's a number of different mechanisms that are thought to mediate that. But I would say far more commonly are the secondary causes. And the secondary causes that we most commonly see are deconditioning. So particularly in somebody who has been ill, and even in somebody who has been used to exercising, has been very active, but then they become ill and they reduce their physical activity, they essentially become unfit. And that deconditioning then leads to worsening fatigue, and then the worsening fatigue leads to more deconditioning. And so all of these things can feed into each other, and they're usually not just one of them is present, but several are present at the same time. So sleep disorders, such as obstructive sleep apnea, pain, anxiety can prevent you from falling asleep, and medication. So often we see people who are taking sedating medications to help them get to sleep and then feel fatigued during the day, and sometimes taking stimulants to keep them awake during the day. And obviously that's not a sustainable approach. So our general strategy for fatigue management is to review the medications to make sure there's no sedating medications and try and rationalize those. To screen for depression, because depression can also cause fatigue and is very treatable. And obviously it's there to treat. And then if there's persistent fatigue, then after that, to screen for sleep disorders. So an overnight oximetry or sleep study to evaluate for sleep apnea. An exercise program. So paradoxically, regular exercise can actually improve fatigue. And so exercising 150 minutes a week can help with fatigue. And then energy conservation strategies. So obviously there's a limit to how much we can do. And so to take strategic naps, to conserve energy for the things that you really want to do during the day. So sometimes you have people who are very disabled with pushing themselves really hard, and sometimes using a wheelchair or an assisted gait device can help reduce fatigue because you're not putting as much energy into doing the routine day-to-day things. The other thing that's really common is spasticity, and this is primarily from spinal cord disease, but it can be from brainstem disease as well. And what spasticity is what you may think of when you think of somebody with a stroke. So if you think of somebody whose arm is held up in a flexed position and whose foot is pointed downwards, and they're rigid, and usually there's associated weakness as well. And this is usually from spinal cord disease. Now, that's obviously the most extreme end of the spectrum, but you can have milder spasticity also. And the main treatment for spasticity, first line, is actually stretching. And the stretching needs to be held for more than 30 seconds because the spinal reflex arc takes 30 seconds to become habituated. And needs to be done twice a day because the effect of the stretching lasts for about 12 hours. So particularly at night, taking about 10 minutes to stretch the major muscles in the legs can reduce stiffness. There are medications which can improve spasticity, including baclofen and tizanidine. And, these do have side effects, and that baclofen can cause some sedation, and tizanidine can worsen weakness. And so we try to use these judiciously. And there are other options such as Botox, which works best for focal spasticity, such as just spasticity in one arm, or even intrathecal baclofen pumps, where a pump is inserted into the spinal canal to deliver baclofen to reduce spasticity. Weakness is obviously occurs with spasticity commonly, and we don't have good treatments, as in medication treatments, to reduce weakness. But we do have good gait aids. And so an ankle foot orthosis is good for foot drop. And these are two different types that are on the market. And the other thing is to use assisted gait devices, as I mentioned, including trekking poles or rollator or a cane if needed. And the thing that I would say patients probably get the most value out of is an evaluation by a physical medicine rehabilitation provider or physiatrist. And these are rehabilitation doctors whose special interest is in rehabilitation, essentially. And so neurologists are good at diagnosis and I would say medical treatment. But from a rehabilitation point of view, the physical medicine rehabilitation doctors are really probably the most useful from a functional point of view. So bladder symptoms then are the other common symptom that people have. And this is complex in that it can be from brainstem disease or from spinal cord disease or not from neurologic disease at all. And the main message that I want you to take home here is about bladder irritants. So most of us probably know about caffeine being irritant to the bladder and alcohol, but you may not be aware that sparkling water or citrus fruits or vitamin C supplementation can also irritate the bladder too. So avoiding those is really the first line of treatment. Again, there are several medical treatments and even stimulation of the sacral nerve or the tibial nerve, which can improve bladder function. But the bladder irritants is really the main thing that, as a patient, that you can do to manage bladder symptoms. So the other very common symptom that's often associated with fatigue is memory problems. And this is really common, not just in patients with histiocytic disorders, but in general in neurology. And the main message is that this can be either primary or secondary. So you can have a primary brain disorder. Obviously, if there's significant brain involvement with the histiocytic disorder, that can cause memory problems. But you can also have memory problems from fatigue or lack of concentration, pain, and other things. Now, the good thing is we have good ways of separating these out. And so the first line thing to do is to do memory testing. And this is the MOCA test, which is a short in-room or bedside test for memory function. But there are much longer neuropsychometric testing, which can take up to 4 hours, which are very detailed. And then a PET scan, which can look for patterns of hypometabolism in the brain, which correspond to certain dementias. And we also do spinal tap in patients who we're looking for coexistent dementia processes such as Alzheimer's disease or even diseases related to Parkinson's disease, which can cause memory problems. So what can we do to protect our brain? Well, the first thing to do is to avoid multitasking, because that really pulls our attention away. And then maintain a normal weight. The main diet that's recommended is the Mediterranean diet, which is high in fish, nuts, and vegetables, and low in red meat. And social interaction and cognitive engagement is also protective to the brain. And these data come mostly from the Alzheimer's disease literature, but I think translate well into the rest of neurology. So I'm going to stop there, and I thank you very much for your attention. I hope you have a wonderful day, and I hope to see many of you in person in future at this meeting or otherwise. Thank you.
We're grateful for Dr. Tobin for doing that presentation at the last minute before he left town.